Hello, welcome to this presentation, Bipolar Disorder and Substance Use Disorder, an Outcomes Management Protocol by Kevin Sell from Adler Graduate School. So first off, let's look at some basic facts concerning substance use disorder and bipolar disorders. Results from the National Epidemiological Survey on Alcohol and Related Conditions showed that substance use disorder co-occurrence was higher among people with bipolar disorder than among people with any of the other mental disorders included in that survey. Studies show that lifetime co-occurrence of substance use disorders for individuals with bipolar disorder ranges from 21.7 to 59%. Also, the 12-month co-occurrence ranges from 4% to more than 25%. Co-occurring substance use disorder and bipolar disorder can worsen manic and depressive episodes. Also, co-occurring bipolar disorder and alcohol use disorder, those individuals can be less likely to adhere to treatment, less likely to respond to treatment as well, more likely to be hospitalized, and more likely to attempt suicide than those with bipolar disorder only. Also, a co-occurring substance use disorder has a substantial effect on bipolar disorder, with a negative impact on symptoms, course, and treatment adherence. Substance use disorders increase the severity of the clinical presentation of bipolar disorder, with increased impulsive and suicidal behavior, which usually results in increased rates of costly inpatient hospitalization. Thus, it would appear that effective treatment of the substance use disorder would increase the effectiveness of the treatment for co-occurring bipolar disorder. So now we're going to look at some interventions for bipolar disorder and substance use disorder. In the Heart and Soul of Change book, we learned that common therapeutic factors, rather than specific techniques and models, are the most robust predictors of client engagement, retention, and outcome. What does this mean? Well, this means that one way to view evidence-based treatments are as diet and exercise regimens, with the clinician's role as something like an expert consultant or a coach who assesses the client's progress and the treatment efficacy and makes adjustments as necessary depending on the client's response or non-response to the treatment. So, what are these evidence-based treatments? Well, a number of evidence-based interventions have been developed for bipolar disorder and substance use disorder, but they're oftentimes studied separately. For example, a study evaluating the effectiveness for bipolar disorder may not include individuals with substance use disorder, and vice versa. That being said, psychotherapy is essential with this co-occurring disorder, and it's essential for enhancing treatment alliance and adherence to treatment and medication, in addition to helping patients develop coping skills to optimize disease management, relapse prevention, and the recovery process. So when we're looking at interventions for bipolar disorder and substance use disorder as a co-occurring entity, we're primarily looking, there's three broad types of interventions. Sequential, parallel, and integrated. So first, sequential treatment involves focusing on the more acute disorder first, then treating the other disorder when the acute problem has been stabilized. And this approach is most commonly used in a hospital setting. There's a limitation, however, and that's the fact that the less acute disorder may not, in fact, be addressed in the future, despite intentions to do so during the acute hospitalization. Then we have parallel treatment. And this ordinarily takes place on an outpatient basis and consists of treating the two disorders in separate settings. So you may have a clinician who's working with the substance use disorder, and then you may have a clinician who's working with the bipolar disorder. So two separate clinicians working in parallel. And then we have the ideal situation, and that's integrated treatment. And with integrated treatment, a clinician and oftentimes a group of clinicians treat both disorders simultaneously. And integrated treatment can occur both at the programmatic level, or at the individual level, or at the group patient level. And this presentation will focus on integrated treatment because that's kind of what we're aiming for. And it'll also focus on the individual and group level of integrated treatment, as treatment will be occurring in an outpatient setting. More on this later. So, first off, since we know that treating a substance use disorder will prove to increase the efficacy of any treatment for bipolar disorder, let's look at some evidence-based treatments for substance use disorders. Cognitive behavioral therapy. We've all heard of this. One way to describe it, I found a very concise definition, is that, quote, maladaptive cognitions contribute to the maintenance of emotional distress and behavioral problems. So, the basic model posits that therapeutic strategies to change these maladaptive cognitions lead to changes in emotional distress and problematic behaviors. Well, how does this work for SUD? A 2010 meta-analysis of 34 randomized controlled trials with, I think there was roughly 2,340 patients treated. They found an overall effect size in the moderate range, D equals 0.45, with effect sizes ranging from small, D equals 0.24, to large, D depending on the substance targeted. Larger treatment sizes were found for treatment of cannabis, followed by treatments for cocaine, opioids, and with the smallest effect sizes, polysubstance dependence. Additionally, cognitive behavioral therapy proved to yield a higher efficacy over treatment as usual in standard drug counseling, primarily measured by a decrease in substance use. So next up, motivational interviewing. Motivational interviewing helps people to explore and resolve their ambivalence about their substance use, or any problem really that they're trying to change, and begin to make positive behavioral and psychological changes. It recognizes that ambivalence about substance use is normal and is an important part of recovery, and that ambivalence can be resolved by working with intrinsic motivation and values. Within motivational interviewing, the therapeutic alliance is viewed as a collaborative exercise, and an empathic, supportive, yet directive counseling style provides the condition for change. So, the principles of motivational interviewing, in brief, include expressing empathy through reflective listening, developing discrepancy between patients' goals or values and their current behaviors, avoiding argument and direct confrontation, adjusting to client resistance, and supporting self-efficacy and optimism. It's very Adlerian. In a way, there are differences, but that's beyond the scope of this presentation. So, how does it work? Well, a 2014 literature review found that at least 32 trials show that motivational interviewing effectively improves treatment adherence and drinking outcomes. And the results from these show a small to medium effect size with variability across settings and providers. So now we're going to transition into looking at some evidence-based treatments for bipolar disorder. Individual psychoeducation. Individual psychoeducation typically consists of about 6 to 21 structured sessions, and these sessions focus on the provision of information about illness etiology, treatment, course and outcomes, strategies to identify prodromes and early warning signs of relapse, and illness coping strategies. How does it work? Well, A 2014 literature review found that randomized controlled trials examining the effectiveness of individual psychoeducation suggest that individual psychoeducation alone offers a benefit over treatment as usual, especially as a strategy for preventing manic episodes, but that more intense interventions such as CBT confer additional advantages over and above individual psychoeducation alone. Next up, we have cognitive behavioral therapy. And I've kind of already given a definition of that, so I'm going to skip diving deep into what exactly CBT is, except to say that in this case, it's similar to CBT for unipolar depression and substance use disorders, but for bipolar disorder, it also deals with cognitive distortions during manic states, known as hyperpositive thinking. How does it work? Well, a 2019 meta analysis of 19 randomized controlled trials comprised of 1,384 patients with type 1 or type 2 bipolar disorder found that CBT is effective in decreasing the relapse rate and improving depressive symptoms, mania severity, and psychosocial functioning. Next, interpersonal and social rhythm therapy. And this was developed by Frank and colleagues to help patients with bipolar disorder address interpersonal problems and regulate their social rhythms. So, what are social rhythms? Well, these are daily activities that help to set or can disrupt underlying biological rhythms. So, examples may include sleep and wake schedules, meal times, start times for work and school, and daily exercise. The thinking here is that improving the regularity of these social rhythms will help to regulate underlying biological rhythms, which would thereby address the supposed link between circadian rhythm disruption and genesis of mood episodes in bipolar disorder. So it's a mouthful, but one way to think about this is that interpersonal social rhythm therapy is basically psychotherapy plus a behavioral strategy plus psychoeducation. Well, how does it work? Well, a 2014 literature review found that interpersonal social rhythm therapy has demonstrated efficacy as both an acute and maintenance treatment for bipolar disorder. Interestingly, it appears that administering it during the acute phase of treatment confers the greatest advantage to patients. It also shows promise as a monotherapy, meaning without medication, for bipolar type 2. And it's typically administered as an individual psychotherapy, but it's also been implemented in routine practice settings as a group intervention as well. So, we've seen evidence based treatments for substance use disorder and bipolar disorder separately. We've also seen that effective treatment for one can increase the effectiveness of treatment for the other. So, what about evidence based integrated treatments for bipolar disorder and substance use disorder? Well, we have something called integrated group therapy. And this typically consists of groups of around 5 to 8 patients for approximately 20 weekly sessions, focusing on themes common to both disorders. And there are three major concepts with this. The first concept is the single disorder paradigm. And this is where patients are encouraged to think of themselves as having a single disorder, for example, bipolar substance abuse, rather than trying to deal with two discrete disorders at once, which can kind of seem overwhelming and confusing. So, thus, thinking of themselves as having a single disorder can help aid in the process of acceptance. The second key concept underlying integrated group therapy is a focus on the common features in the recovery and relapse process with the two disorders. So patients are told that the same kinds of thoughts and behaviors that will help aid in their recovery from one disorder will also help them in the recovery process from the other disorder. Flipping that around, thoughts and behaviors that may increase the risk of relapse from one disorder can also increase the risk of relapse from the other disorder. So for example, thoughts and behaviors, are therefore labeled recovery thoughts, recovery behaviors, or as relapse thoughts and relapse behaviors. And kind of similar, harkening back to the single disorder paradigm, patients are encouraged to focus on the overall recovery process rather than the recovery process from each disorder separately. And third common feature here is also the relationship between the two disorders. If commonalities in the recovery and relapse process in the two disorders can be seen as parallels between the two disorders, the focus on the relationship between the two disorders can be viewed as the intersection between their bipolar disorder and substance use disorder. So, for example, clients are often told that using substances will negatively impact the course of their bipolar disorder, and that not adhering to their bipolar disorder medication will increase their risk of relapse for their substance use disorder. So, again, the focus is on the relationship between the two disorders, and harkens back to the single disorder paradigm. So, how does it work? Well, one randomized controlled trial found that integrated group therapy was effective at reducing drug problem severity, encouraging abstinence, and decreasing the risk of mood episodes as compared to standard group drug counseling. Additionally, a 2012 literature review also summarized the research, and I quote here: "Integrated group therapy has been demonstrated to be efficacious for this common and difficult to treat population." Another evidence-based integrated treatment for bipolar disorder and substance use disorder that has been studied is early recovery adherence therapy. And this was specifically designed to help patients with bipolar disorder and co-occurring substance use disorder. And it was designed to be used during the early phases of recovery from an acute episode, so it can be very useful. And in short, it integrates principles from motivational interviewing, relapse prevention, and educational and disease management approaches. A randomized controlled trial showed a significant advantage over 12-step facilitation therapy on decreasing alcohol use and depressive symptoms. So it hasn't been studied a whole lot. We're not quite sure of its efficacy regarding other substances aside from alcohol, but the early research is showing promise, and this type of treatment should definitely be considered as an integrated treatment given the paucity of research on integrated treatments in general. Okay, now we're moving into part 2 of this presentation, the outcomes management protocol. Program description of this hypothetical program. It is an outpatient counseling clinic specializing in co-occurring disorders, treating adult men and women. We will be providing integrated treatment, and this means that we'll be giving individual counseling, group counseling, and psychiatric services. So, kind of high level, what are the target treatment goals if someone comes in with a co-occurring bipolar disorder and substance use disorder? Well, both disorders have similar phases of treatments, which range from acute stabilization to maintenance treatment. So, thus, the treatment goals are both acute stabilization and maintenance. This means symptom reduction of both disorders and quality of life improvement. And with quality of life improvement, what I'd like the clinicians in this clinic to do is shift from a disease and illness model to wellness and recovery. And this means focusing on wellness and recovery as a strength-based and adherent approach, and includes interventions to help clients become more proactive in managing their overall health and well-being. Focuses on reclaiming important aspects of life that are oftentimes lost with this co-occurring disorder, or discovering those aspects for the first time. So the Substance Abuse and Mental Health Services Administration has identified several essential dimensions of a holistic approach to recovery and wellness. And these are outlined in this diagram here, or not diagram, but table. And dimensions of recovery here are include health, home, purpose, and community. And then it shows the dimensions of wellness within these dimensions of recovery. So for health, we have physical and emotional health. For home, we have environmental and financial. Purpose, we have intellectual, occupational, and spiritual. And community, we have social. So while we are focusing on symptom reduction, we're also focusing on wellness, functioning, life satisfaction, and, self-actualization, really. So what are some variables to consider when developing treatment goals and outcome measurements? Well, we have client factors and extra therapeutic factors first. And one of these is the client's perception of psychotherapy. What this simply means is many of our clients come in with preconceived notions about what psychotherapy and counseling looks like. They may have seen such depictions on television or film. Some of the clients may come in highly resistant to therapy. Others may come in excited. So we have to, I'm sorry, I got that on there now. So we do have to take this in mind when we're molding our approach to the client. Next, we have early change. Much of the research presented in the Heart and Soul of Change shows that those clients who do show significant symptomatic relief are early responders to treatment, meaning like between 1 and 7 sessions. So if a client's not responding early, we need to change our tactics. We need to get them in that early phase to ensure the efficacy of the treatment. Client expectations. This is kind of similar to perceptions of psychotherapy. May include their expectations for what psychotherapy entails and is involved, but also includes their expectations for their own prognosis, what they see their future looking like. Do they see themselves recovering from this co-occurring disorder or from one or the other disorder? So again, we tailor our approach to the client's expectations. Stages of change. Where is the client in the stage of change? Contemplation, pre-contemplation, etc. And again, we mold our approach as clinicians to where the client is in the stage of change. So the Heart and Soul of Change gives this great example where, if a client's in the pre-contemplation stage, the clinician assumes the position of a nurturing parent. If the client is in the contemplation stage, we assume the position of a Socratic teacher. In the action stage, we're an experienced coach and a consultant during the maintenance stage. So I kind of like that framing of how to tailor our approach to where the client's at in the stage of change. We also need to take into account the client's social and community supports. These are major factors in recovering from co-occurring disorders or any sort of disorders, and they're major factors in the wellness model, which was kind of discussed in the last slide. Also, we need to be taking a strength-based approach. We need to ask our clients what's worked in the past. If we can't find anything, we need to find out what their strengths are and build on those strengths and capitalize on those strengths, because that's really what's going to help our clients be successful in the long run. So the next major variable to consider here is the therapeutic relationship. The first thing here is we need to privilege the client's experience. Research shows that clinicians tend to oftentimes think that what they're doing is more effective than it actually is. Let's put it that way. So what we need to do here is, the outcome measures that we're measuring not only measure what the clinician thinks should change and is changing, but also the client's experience. as well as the client's rating of the therapeutic relationship. And we'll get to ways to measure this in subsequent slides, but we need to privilege how the client sees what's going on. There are also different types of empathy. And since empathy is so important to the therapeutic process and the relationship, we need to tailor our type of empathy to what the client responds to best. Three major types: cognitive, affective, or nurturing and disclosing. So again, this is kind of the major theme of this. I reiterate it, and I will be, is that we really need to individualize our approach to the client. Goal consensus. This means that the clinician and the client are in agreement on treatment goals and expectations. They collaborate, meaning they're both involved in the relationship. And, the therapy and the treatment should be presented as a team effort, encouraging feedback from the client. And we as clinicians don't always run the show. We're doing this for the client. So, additionally, management of transference and countertransference. Pretty obvious. Psychotherapy 101 must not be forgotten here. Rolling with resistance. Different types of clients come with different types of resistance, and different types of resistance call for different approaches. For one easy example, a highly reactive client may require a much more non-directive approach. If we were to take a very directive approach with such a client, they may not come back. And, this has kind of been covered, but we need to be actively monitoring and adapting the relationship to the particular client's needs. And this is an ongoing process. It's not just you do it at the beginning, you do it at the end. It's throughout the treatment. Lastly, if we're doing group therapy, we want to ensure that there's cohesion in the group therapy. Cohesion just means it's the forces that help the participants stay in the group therapy and stay engaged in the therapy. The next major variable to consider here is the expectancy and placebo effect. What this means is that the very interaction between the doctor or the clinician and the patient may have a healing property of its own. It's the fact that the expectation that the clinician or the doctor will cure the client, this can stimulate endorphins or a response in the client and make them feel better before they've even taken the drug or undergone the treatment. This doesn't mean that anything goes in treatment, however, rather it reinforces the notion that a structure and focus on treatment is important. So one way to think of therapy, and I really like this, is as a healing ritual, an organized method for enhancing expectations of change. So thus, the client's expectancy really underscores the importance of the relationship and individualizing the treatment to the client. Additionally, it should be mentioned that patients come to therapy or treatment with an explanation for their distress. Oftentimes, it could be a cultural, formed from their own psychological beliefs and their own histories. And these explanations are oftentimes not adaptive, meaning they don't allow for solutions. Otherwise, they wouldn't be coming to treatment. So what psychotherapy can do is can provide an adaptive narrative for the client's suffering. Thus, the client then comes to believe that participating and completing treatment will be helpful in coping with their problems. So critical to this is that patients believe the explanation provided, and they believe that the treatment actions will be helpful for reducing their suffering. So again, we need to tailor our approach and make sure that both the clinician and the client believe in and expect that the healing ritual, meaning the treatment modality and the relationship, will help the client's suffering. Next, models and techniques. Well, thanks to the work began by Liborski and many others, we now know that while psychotherapy is effective, no one model or technique is universally applicable and generally more efficacious than any other. So, what are we to do? This is where the contextual model comes in. And I'm going to quote here from page 145 to 146 out of The Heart and Soul of Change. In contrast to traditional theoretical models, which propose that change is due either to specific technical operations or various common factors, the contextual model proposes that therapeutic change occurs because there is a single theory or rationale that is acceptable or believable to both the healer and the client. Thus, techniques work in large part due to the placebo effect and the client's and the therapist's expectation that they do work. Kind of talked about this in the last slide. So what this means for practice is that we need to be familiar with many different therapeutic orientations and techniques, and we need to tailor our approach to fit with the given social context, cultural context, and our client's worldview. So this is an ongoing process with the client, and we need to monitor through feedback, more on this later, the client's acceptance and agreement with the treatment and the goals of therapy. So, the best methods are 1. Intended and believed to be therapeutic by both the clinician and the client. Delivered with a clear explanation and rationale. And acceptable to the client. All right, so now let's look at some of the measurements that we'll be taking at this clinic. The first is the Mood Disorder Questionnaire, and this is a self-report questionnaire designed to help detect bipolar disorder. It focuses on symptoms of hypomania and mania, which are the mood states that separate bipolar disorder from other types of depression and mood disorders. It has 5 main questions, first question having 13 parts for a total of 17 questions. It was originally tested with adults, but has also been studied in adolescents, ages 11 and above. And it takes approximately 5 to 10 minutes to complete. So, one study found that it can be useful to rule out bipolar disorder in patients with substance use disorder. So, this is a great tool to use upon intake. It's a wonderful initial screening tool. But the problem is that many substances mimic the symptoms of bipolar disorder. So if the test yields a positive result, this just indicates that a more comprehensive diagnostic interview should be done to determine if such states occurred in the absence of substances. So again, it's a great broad initial intake assessment, or not even assessment, screening tool. And it's not suitable to measure progress over time or outcomes, though. Next up, we have the Young Mania Rating Scale, and this is one of the most frequently utilized rating scales to assess manic symptoms. The scale has 11 items, and it's based on the client's subjective report of his or her clinical condition over the previous 48 hours. Additional information is based upon clinical observation made during the course of the clinical interview. And the items are selected based upon published descriptions of the core symptoms of mania. So, in our case, in this clinic, this can be collected upon intake to assess bipolar disorder baseline symptoms. This can also be collected and will be collected throughout treatment to track symptom reduction progress. And this will be collected at the end of treatment as well. So this is a great tool to measure symptom reduction or non-reduction, really, or for both, just assessing where the symptoms are at for bipolar disorder. The great thing about this, too, is that it takes into account both the client's self-assessment, which we've seen is important, and the clinician's assessment. We also have the Beck-Raphaelson Mania Scale. This is regularly utilized in studying co-occurring bipolar disorder and substance use disorders. It's very similar to the Young Mania Scale, and it's an 11-item questionnaire assessing symptoms of mania on a scale of 0 to 4. So again, this can be collected upon intake to assess bipolar disorder symptoms, baseline symptoms, Can be collected throughout treatment to track symptom reduction or non-reduction progress, and can be collected at the end of treatment as well. Personally, I would go with the Young Mania Rating Scale, but if there are other clinicians working at this clinic who would prefer the Becker-Feilson scale, that would be fine. Either would work as an ongoing measurement of bipolar disorder symptoms throughout the course of treatment. Okay, moving on to substance use disorder measurements. We have the Addiction Severity Index. This is a 155 item multidimensional structured interview for assessing alcohol and drug dependence. It assesses frequency of drug and alcohol use, as well as other psychosocial areas affected by use, including there's a psychiatric subscale in there too. So the ASI consists of 7 subscales assessing past 30-day and lifetime alcohol use, drug use, medical problems, psychiatric problems, family and social problems, employment and legal problems. One of the things I like about this test is that it takes into account both subjective ratings of the problems by clients and objective tests, such as laboratory tests, across each scale. And this provides an overall severity rating. So it's wonderful as a broad initial screening tool. It can help us establish a baseline when the client comes into the clinic for treatment. That being said, it's given its very comprehensive nature, it would be incredibly cumbersome to repeatedly administer and collect throughout treatment. So we would not be using it for that. What we would be using, though, is the Leeds Dependence Questionnaire. And this was developed as a 10-item assessment and outcome measure for treatment of substance dependence. So in the Leeds, severity of dependence incorporates broader notions of psychological dependence and doesn't simply measure rates and quantities of consumption and physical dependence symptoms. I really like this. For instance, if we find out that someone's drinking 3 drinks a night, that might be useful data, but it doesn't give us a whole picture to the client's level of or self-reported ratings of life satisfaction, stuff like that. So I like this. I like this questionnaire. So again, it's not limited to specific substances or quantities of substances, and it's more about the client's perception of their relationship to substances. So like I said, it's 10 items. This is very quick. It's very easy to use. And this is one that I would use throughout treatment. Maybe not every session, but definitely at the beginning of treatment, maybe monthly, depending on the client, and at the end. And this could also be a wonderful follow-up tool too. So once a client completes treatment, let's say 6 months, a year, this would be one of the outcome measures that would be wonderful to use. Okay. Next, we have the adult outcome measure. So we've already seen how we're going to measure bipolar disorder symptom reduction and substance use disorder symptom reduction and broader functioning. So now we're going to look at a couple tools that I would use in this clinic to measure broad levels of client functioning as well as client's perception of their own progress and the therapeutic relationship. So the first here is the adult outcome measure. This is a 45-item self-report measure, and this would be repeatedly used throughout the course of treatment and at termination. So in accordance with several reviews of the literature, the adult outcome questionnaire was conceptualized and designed to assess 3 broad domains of patient functioning. So I like this. Those 3 domains, psychological disturbance, interpersonal problems, and social role functioning. Very Adlerian. Just got to add that in there. So it provides a total score based on all 45 items, as well as symptoms, distress, interpersonal relations, and social role subscale scores. And also, each of these subscales also contains some items related to the positive quality of life of the individual. And research has indicated that this is a psychometrically sound instrument with strong internal consistency, adequate test-retest reliability, and strong concurrent validity. So I really like this test, and I would give this throughout the course of treatment. Depending on the client, this could be something every other week, monthly, and would also be great as a follow-up. So 6-month, 1-year follow-up to see how the client is doing. Next, we have the PCOMS outcome rating scale. So since early progress is a strong predictor of success, the PCOMS measures the client's perception of their individual, interpersonal, social, and overall sense of being. And this would be used throughout treatment to assess early progress. So if we're seeing if it's 2 weeks into treatment and the PCOMS rating scale is very low, that indicates to us clinicians that what we're doing isn't working, and we need to change our approach. It's very similar to the outcome rating scale is the PCOMS session rating scale. It's similar to the outcome rating scale in that it measures the client's perception, but in this case, it doesn't measure their perception of their well-being, but it measures their perception of the quality of the therapeutic alliance. And since we've seen that the therapeutic alliance is critical to outcomes, this is a very, very useful tool. And this I would use throughout treatment to assess the quality of the therapeutic alliance. I would use the outcome rating scale and the session rating scale on a weekly basis. This gives us accurate, up-to-date information on both the client's sense of well-being and their sense of the therapeutic alliance. So this gives us as clinicians up-to-date feedback so that we can tailor our approach and change things as needed. So, what is the measurement protocol? I just went through a bunch of tools, how we can measure outcomes and get feedback, but what is it going to look like in this particular instance at this particular clinic when dealing with co-occurring bipolar disorder and substance use disorder? Well, for our initial screening tools, we're going to use the mood disorder questionnaire for bipolar disorder and the addiction severity index for substance use disorder. This will give us an excellent baseline upon which to assess future progress and also kind of give us a sense of where the client's at, where they may be in their state of change, and what type of therapy might be most applicable and beneficial to them. Next, for our symptom reduction assessment tools, we're going to use the Young Mania Rating Scale for bipolar disorder and the Leeds Dependence Questionnaire for substance use disorder. And these tools will be given at intake, during treatment, might be weekly. I'm envisioning more every other week and monthly, and at the end of treatment. Additionally, these can be given as follow-ups, maybe say 6 months, 1 year, just to see how our clients are doing. Next, to assess client functioning, we're going to be using the Adult Outcome Questionnaire. Again, this will be given at intake, during treatment periodically, again, every other week, monthly, at the end of treatment. And similar to the symptom reduction assessment tools, this can be given as a follow-up, say 6 months to a year after treatment has ended. Client factors and therapeutic alliance tools. We're going to be using the PCOMS outcome rating scale and the PCOMS session rating scale. Again, these will be given at intake, but these will actually be given after each session and at the end of treatment. So, final question, when do we end treatment? Well, my answer is it depends. There is no universal answer for each client. It's going to be different for everyone. But for instance, if we're using integrated group therapy, which is a manualized protocol of about 20 weekly sessions, well, the integrated group therapy is going to be done after those 20 sessions. That being said, if the client still wants to attend therapy with their clinician, see the psychiatrist for medication management, we would obviously be able to facilitate this. So I think My answer to this question would be, well, it depends on the client and it depends on what the client wants. Uh, as a clinician, though, we do have a responsibility where if we're not seeing any improvement in the client, and it just kind of seems like we're spinning our wheels, well, there's no reason to keep doing what we're doing, and maybe then we would refer them elsewhere. That being said, if a client has reached full functioning and we don't think that therapy is benefiting them, then we do also have an obligation to terminate therapy in an adequate way. So, some final thoughts on measurements. Feedback it can help us determine when therapy is not effective. It can help us identify worsening symptoms. For example, if a client's symptoms appear to be getting worse, this can alert the clinician that a client is not responding to treatment. So, this data can function as a sort of early warning sign that a new strategy and intervention needs to be adopted. Can also provide opportunities to make changes to treatments. And also client self-reports provide novel information to us, and that's why I included so many self-report uh, assessment tools in this presentation. As we said before, clinicians tend to be overly optimistic about the client's progress. So the inclusion of these client self-reports and client perceptions of change are included, and this provides novel information to us, like I said. On a programmatic level, feedback and measurements and outcomes can provide useful information about the clinician's effectiveness. So, say if we have 5 clinicians working at this clinic, and one clinician is continually getting feedback that, very low session rating scales. Additionally, maybe their outcomes are much lower than the other clinicians. Of course, we need a lot of data to be able to look at this in an accurate way. Well, this can provide us with information that, hey, maybe this clinician is underperforming or there's room to grow. So then we could meet with them and figure out opportunities to help them along and increase their effectiveness. Additionally, this can give us information about the program as a whole's effectiveness. We can compare ourselves to possibly other programs. We can compare our program's effectiveness to rates of spontaneous and self-generated change. We can see, if we're seeing that we're doing no better than rates of spontaneous self-generated change, well, hey, we got to step up our game a little bit and maybe employ some different interventions. And finally, at the heart of this is we need to know if what we're doing is working. And we got 3 pages of references here. I'll kind of linger on each one for a sec.